Good afternoon. I am Dr. Vinita Ramnani, Chairperson, Scientific Committee, Madhya Pradesh Ophthalmic Society. I welcome you all in the last session of Preceptors of Future. And we had 5 different web series from different divisions, and we have today Ujjain and Indore division mixed presentations. And I am thankful to all the 3 coordinators, Dr. Aditi, Dr. Shweta, and Dr. Pankaj. They did an excellent job for each and every aspect of this whole program of Preceptors of Future. I would like to thank all the judges. With this, I invite Dr. Rajiv Gupta, the Secretary, Madhya Pradesh Ophthalmic Society, to give a welcome address. And after that, Dr. Shweta will tell us the rules of webinar as well as the presenters which are participating today. Dr. Rajiv, are you there?
I'm here. Yes.
Sir, welcome address, please.
Oh, it's a tough task. Anyway, good afternoon, everybody. Good morning. Good afternoon, every student. It's a great privilege to welcome you all. Definitely, because we have got the immense, good expert team. So be assured, rest assured, they'll be fair enough to judge them. And I hope this is going to be a great platform to have the good learning. So I welcome and encourage the participant to discuss and becomes the winner. So once again, I welcome you all. Thank you.
Thank you, Dr. Rajiv Gupta. I welcome Dr. Rakesh also. So Dr. Rakesh, Dr. Pankaj, and Dr. Manav will be judging all. And Dr. Shweta will be judging Ujjain candidates. And Dr. Shubhra will be judging Indore candidates. Okay. With this, I invite Dr. Shweta Walia for introducing the rules, which everyone knows, and then today's presenters.
So best of luck to all the presenters. The judges, Dr. Vinita Ramnani has announced. We have today 12 presentations, and the presentations will be judged out of 100 marks, 20 each for quality of presentation, way of presentation, relevance of content, adherence to time and slide management, and discussion. The final judgment will be by the judges if there any query or contradiction arises. So best of luck to all the participants, and I hand over it to Dr. Vinita Ramnani.
Thank you, Dr. Shweta. Before we start, I would like to announce the name of the winners, which are already there from the different divisions. Dr. Mehak Gupta from PCMS Bhopal. She will be competing, and we started this webinar on 15th of January. So that's practically 2 months now. The second participant for the final is Dr. Sadhyaja Smita from Gwalior Medical College. Then Indore, we have kept blank because few of the presenters were not available and the rest will be doing today. So we will be discussing, we will be announcing the result of Indore division tomorrow. Then from the Jabalpur is Dr. Palak Patwa, and from the Rewa division is Dr. Ashish Jain. So I wanted to congratulate all the 4 finalists. The other 2 will be joining soon, and the result will be declared tomorrow. So all the 6 participants, they have to be there physically with their mentors at Jabalpur. That is 9th of April. And there will be a Preceptors of Future final program. And in this final program, the national judges will judge. There will be 4-minute case presentation followed by 2 minutes rapid fire round of a quiz to each and every participant. So all the winners, be ready. You have to fight, but this fight will be much easier because out of 6, 3 winners. So you all are winners. So with this, we can start today's presentation, which is the first presentation is by Dr. Yuvraj, na, I suppose. Dr. Yuvraj Hardia is there.
Yes, ma'am.
And he will be presenting on steroid-induced glaucoma, and the mentor is Dr. Shubhra Mehta. Today is World Glaucoma Day, so it is a very good start. So we will be all celebrating World Glaucoma Week from 12th to 18th of the March, and we will be creating a lot of awareness to our patients. So these young dynamic ophthalmologists of future probably have long way to go, and steroid is one of the irreversible blindness we are fighting with. So to begin with, we should not create an iatrogenic complications in our patients. So steroid-induced glaucoma is the one which we all should be careful about. So for this, Dr. Yuvraj Hardia is there to present. Dr. Hardia, please.
Good afternoon, respected seniors and consultants. So today I'm going to.
You can go in slide mode.
Is it visible?
Share screen.
Not yet.
Slide. From
Ma'am, is it visible?
The slides are visible, but they are not in the slideshow mode. So we can see only the small portion of your slide, not the full screen.
back करो. Exit. ये वाला stop sharing. Share.
Yes. Okay. Yeah. Oh.
That's perfect. So that's a learning for each one of you, that you should go for a screen and then slideshow mode.
Good afternoon, respected seniors and consultants. So I'm going to start with the topic steroid-induced glaucoma. Steroids are the most commonly prescribed drugs which are used mainly in the treatment of autoimmune and inflammatory conditions. Steroid-induced glaucoma was first described in 1950 by Dr. Gordon and Dr. McLean with the observation of glaucoma following the use of systemic adrenocorticotropic hormones and topical or systemic steroids. Individuals who develop an increase in IOP following steroid use are referred to as steroid responders. So coming to the definition, the steroid-induced glaucoma is an iatrogenic secondary form of open-angle glaucoma resulting from prolonged use of topical, periocular, intravitreal, inhalational or systemic steroids. The epidemiology, the incidence of the steroid responsiveness in the general population, 5% are the high responders, 35% are the intermediate responder, and 60% are non-responder. So according to this, there is a classification which was given by Becker and Armeli. In this, they have characterized it into three groups: low, intermediate, and high. In this, the high responders which was given by Becker was that the final IOP after the steroid use was more than 31 mmHg, and in the classification which was given by Armeli, it was the IOP difference or IOP change which was more than or equal to 16 mmHg. So coming to the mechanism, the corticosteroids lysosomal membranes, which leads to the accumulation of polymerized gags, that is glycosaminoglycans. These polymerized gags becomes hydrated, which causes biological edema, thereby increasing the outflow resistance and causes increase in the intraocular pressure. The other mechanism induced, there are other genes like FKB06 binding immunophilin, and the most important, that increased expression of the MYOC that is responsible for coding myocilin, is also responsible for causing steroid-induced glaucoma. The conditions or the causes which are includes are the number one is the exogenous causes, in which the vernal keratoconjunctivitis is the most common cause, around the 42%. The rest are the uveitis and nephrotic syndrome, and other causes includes IV triamcinolone and maybe post-refractive surgery and asthmatics who are using the inhaled corticosteroids. Endogenous causes also includes like the Cushing syndrome. The risk factors of the steroid-induced glaucoma are the family history of primary open-angle glaucoma, diabetes mellitus, high myopia, connective tissue disorder like rheumatoid arthritis, and very young and older adults are more predisposed to this condition. Eyes with the pigment dispersion syndrome or traumatic angle recession are common risk factors. So coming to the route of the administration, periocular or intravitreal are the most common route of are the most common potent causes for the steroid-induced glaucoma, which is followed by the topical, then systemic and skin. Topical includes the betamethasone or dexamethasone or prednisolone are the most common, are the most potent steroids which causes steroid-induced glaucoma, followed by the FML, followed by lotepred. Steroid use close to eyes has a higher risk of rise in IOP than the use of steroid at the distant site. IOP increasing propensity is directly proportional to anti-inflammatory action of the drug. Coming to the clinical presentation, which is elevated intraocular pressure, optic disc changes like thin neuroretinal rim or 0.9 CTR can be seen, visual field loss, open angle on the gonioscopy can be seen. Other features which are associated with it maybe can be posterior subcapsular cataractosis, mydriasis, and atrophy of eyelid skin. Why steroid drops are such a pain? Because it is easily available in the market, it is cheap, and immediate relief of symptoms can be seen. And the last cause is due to that the unregulated self-prescription. The IVT or Ozurdex, these are IVT and Ozurdex are the intravitreal dexamethasone implants. It also causes steroid-induced glaucoma, in which the 28 to 50% patients have been reported rise in intraocular pressure after the first injection, and the 65% patients have been reported with rise of intraocular pressure after second injection. Risk is directly proportional to the baseline IOP in the normal patients. Position of implants next to pars plana or ciliary body has the maximum propensity. Problems in children with steroid-induced glaucoma, it remains undetected till advanced glaucomatous stage has occurred. Perimetry normative data is not available, hence the clinician needs to focus on the optic disc damage. Management is that we should stop steroid wherever possible, and we should substitute steroids with like other agents like the NSAIDs, Olopad, tacrolimus, lotepred, and we can add lubricants in that condition. Anti-glaucoma treatment, if the pressure is not intraocular pressure does not come within normal limits, then we can start beta blockers and carbonic anhydrase inhibitors. We should avoid alpha agonist in young children because it can cause drowsiness or apnea. Prostaglandins are not here first line of drugs. Oral acetazolamide can be used if pressure lowering is not achieved. Surgery is usually indicated in case of high presenting IOP or long duration of steroid use. So coming to the some take home messages that the parents should be advised to use steroid eye drop cautiously in children affected with BKC. We should regularly monitor the IOP in whom we are prescribing the steroids eye drop. The unwarranted and irrational use of steroid in developing countries by local medical practitioner, as well as unmonitored self-use by patients themselves, point to the lack of awareness about disease. So we should always instruct parents that about the injudicious use of the topical steroids, and we should explain them that they should come for the regular follow-up after relief of the symptoms. So these are my references. Thank you.
Thank you, Dr. Yuvraj, for wonderful presentation. And not only we should warn our patients, but we should also be aware of this entity. So most of the doctors, they might miss. And once we write our prescription, we should be carefully writing that it has to be continued for 3 weeks or whatever duration and needs to stop. So we never prescribe that only 3 weeks. We just write that 3 weeks and after that you should stop. Otherwise, patient keep on purchasing. Thank you so much. With this, the topic is open for discussion. Dr. Pankaj.
Why steroids should be given in a tapering dose whenever we are using it in allergic conjunctivitis or VKC? What is the rationale for the tapering of the dose?
Sir, we should taper it because actually the steroids are the inhibiting agents. We should not suddenly stop abruptly. Do not stop the steroids because it can cause means, sir, it may cause that.
No problem, Dr. Yuvraj. Dr. Pankaj, you can explain him.
It is important because otherwise it will IOP will shoot up again, and whenever you taper the dose, it should be 5 days a week, 3 days a week, 2 days, and after that you start with NSAID and other drugs, so that there will be no change in the IOP and no change in the other inflammatory condition. If you stop it suddenly, then that will go back to the same position again.
Dr. Shakya.
Very nice presentation, Dr. Ibrahim. So my question is why the actually you mentioned that the postage subcapsular cataract is most common, and when you give the steroid in any form. So what is the reason behind it? Why the PSC is the most common type of the cataract in the industry? Can you hear me?
Yes, sir. Sir, it is due to the maybe due to the tryptophan metabolism.
No. So what is the mechanism of actually the development of the cataract due to the steroid?
No problem, Dr. Yuvraj. You have mentioned the mechanism of steroid-induced glaucoma. And Dr. Shakya wants to know the mechanism for cataract. So, Dr. Shakya, can you do the favor for other PGs? What is the mechanism? Even I don't know. Batao?
Actually, the steroid inhibit the growth factor of in the aqueous. So why this reason is prevent differentiation epithelial cells and their aggregation into the lens fiber. So why this reason this and different cells actually continue it across the equatorial zone. So it accumulate postage subcapsular. So this reason is very difficult.
Yes, sir.
Okay, thank you. Dr. Shweta?
Dr. Yuvraj, it was a very wonderful presentation. My only question is, what are the safe steroids?
Ma'am, safe steroids like ma'am, the agents like lotepred, prednisone, or fluoromethalone. Ma'am, these have a less penetrative power. So, ma'am, it doesn't actually causes much rise of intraocular pressure and condition. We can substitute with the with more potent agents like prednisolone or.
And if with loteprednol also the pressure is rising, the patient is responding to that also. What other drug you can give?
Ma'am, we can go for ma'am olapatadine eye drops, or where we have tacrolimus eye ointment, which can be used in this condition.
And what precaution when you are prescribing tacrolimus to the patient? how will you counsel him? What side effect it can happen, and what extra care you'll ask him to take?
Ma'am, actually, tacrolimus is also an immunomodulator agent. So,
Actually, it comes in ointment form, and whenever the
point.
patient applies, if he applies more into the eye, like many people say कि कोई भी ointment होता है तो what they say, काजल जैसा लगा लो, है ना? अगर वो पूरा भर के पूरी eyes में लगाएगा tacrolimus, the patient will have a burning sensation. मतलब that burning
Preceptine Kennicott and dexamethasone implant. You said that there is no difference between the rise of intraocular pressure, and this also happens with dexamethasone implant. Is that so? When you are injecting Preceptine Kennicott, or you are injecting
Yes, sir.
implant,
Yes,
is
sir.
IOP rise?
Yes, sir. It can also lead to intraocular pressure rise. Sir, if the intraocular, sir, in such condition, if the intraocular pressure is on a higher side, then we can go for topical like anti-glaucoma agents. But if the
You're
intraocular
getting the
pressure,
question wrong. The point is the response to IVTA or dexamethasone implant with steroid-induced glaucoma, is it the same fashion? Or is there any difference between the steroid-induced or rise or IOP with the use of these two different steroids?
sir, that it implant, sir, that the IVTA will be more having the more potent steroid responding action than the posterior subtenon implant, posterior subtenon depot.
Watch out, fine. Before initiating steroids, which patients you should be very much watchful of rise of IOP?
IOP.
Or is it like uniformly accepted? Or there are few patients that you should be very careful of starting steroids with? Any particular age group of any particular?
Sir, the young, sir, mostly that elderly patients should be, we should take precaution in elderly patients and the young patients, young children who are less than 10 years of age, because the steroid-induced glaucoma has highest risk factor in that bimodal distribution of younger age group and the more elderly group.
It's before 6 and then the elderly age group. Also, you should be careful if the patient has glaucoma history. Also should be careful of initiating steroids if the patient has connective tissue disorders or there is high myopia. These are questions that you should be watchful of before starting steroid in any manner. Fine. Thank you, Yuvraj. Nice presentation.
Thank you.
Thank you, judges. It's a wonderful learning. We keep on learning many good things, even as a consultants also. So, but we have to curtail our discussion because we have 12 lined up presenters. The next presenter is Dr. Kshitij Gupta. He is also again from Ujjain. The mentor is Dr. Shubhra Mehta, and he will be presenting on astigmatism. Dr. Kshitij.
Good afternoon, ma'am. Can you hear?
Yes.
Okay. Okay. Good afternoon, ma'am. My topic of presentation is astigmatism. Astigmatism, a condition of refraction where a point of light cannot.
Your presentation is not ready, so please share your screen first.
Yeah. One second. Can you see it, sir?
No, not yet. Dr. Yuvraj, have you disconnected? Kshitij, are you able to see the share screen option?
Yeah, one second. One second.
Yes. Now it's okay. Only slideshow mode. Yes, perfect. You can start.
Okay. Good afternoon, ma'am. Good afternoon, everybody. My topic of presentation is astigmatism. Astigmatism, a condition of refraction where a point of light cannot be made to produce a punctate image upon the retina by any correcting spherical lenses. Types of astigmatism: corneal astigmatism and lenticular astigmatism. Corneal astigmatism, when the cornea has a direction of greatest and least curvature at right angle to one another, the condition is called regular astigmatism. Another condition where it is defined into two forms, with the rule and against the rule astigmatism. Another entity is called oblique astigmatism and irregular astigmatism. So here is an example depicting the against the rule and with the rule astigmatism. After ulceration, the surface of the cornea becomes irregular, so the rays of light passing through the media becomes irregularly reflected, and it is called irregular astigmatism. It can only be occasionally improved by contact lenses. Here is a picture depicting lenticular astigmatism. Age distribution from birth to 4th year, the most common astigmatism becomes against the rule as the person ages from childhood to adulthood. With the rule, astigmatism becomes more common and person becomes older adulthood above 40 years. Again, against the rule, astigmatism becomes more common. This is due to probably the pressure from the eyelid as depicted here. And another surgical dynamic, especially cataract surgery, leading to flattening of the cornea at the incised meridian, causing flattening at the incised meridian. Retinal detachment surgery causing indentation of the cornea as depicted here can cause astigmatism. Pterygium can cause astigmatism, and removal of pterygium can cause release of that plane and causing resulting in reduction of the astigmatism at that plane. Exact etiology is unknown, but there are many factors such as genetics, eyelid pressure, and intraocular motion, and even visual feedback can help. Optics of astigmatism. Regularly astigmatic surface is supposed to have a toric surface. So how do you define a toric surface? It is a cut section of the diagram depicted here, which is called a torus. Torus is a surface of revolution generated by a revolving circle in a three-dimensional space about an axis that is coplanar with the surface. So stem conoids, the ray after refraction will be perfectly symmetrical when referred to the vertical and horizontal planes, but they will have two foci. The distance between the two foci is called focal interval of stem. Here's the Gulstrand reduced schematic diagram from the diagram of the eye. From anterior to posterior, first one, compound hypermetropic astigmatism, simple hyperopic astigmatism, mixed one, and then you have simple myopic astigmatism and the compound myopic astigmatism. In terms of refractive correction, these are the enlisted ones. Transposition, a word about transposition. The new sphere is an algebraic sum of the old sphere and the cylinder, and the new cylinder has the same value as the old cylinder but with the opposite sign. The axis needs to be changed by 90 degrees. Example of simple transposition and the transposition with axis not 90 and 180 degrees. Symptoms of typical astigmatism: blurring of vision, asthenopic symptoms, tilting of head in some patient, and squinting of the lens. How to investigate a patient if you're suspecting astigmatism? You can see retinoscopy reflexes, which are characterized by 4 typical reflexes, include break, width, intensity, and skew. Keratometry, corneal topography. Astigmatic fan test can be used, in which test charge with radially arranged lines are visible, which may be used to determine the axis of astigmatism. Jackson's cross cylinder test. And stenopic slit, typically used in central corneal opacity, in which autorefraction and retinoscopy can't be used. There is a picture depicting stenopic slit. Optical management include prescription of appropriate cylindrical lenses and contact lenses. Corneal intervention, which is incision made in the cornea at the steeper meridian, causes flattening of the incised corneal meridian. And other modalities: astigmatic keratotomy, transverse incision, arcuate incision, limbal relaxing incision, and photoastigmatic refractive keratotomy, astigmatic epiLASIK, LASIK, and CLASIK. Main modality is lenticular intervention, which is toric IOLs. Management of post-keratoplasty astigmatism, suture removal, relaxing incision, astigmatic LASIK, corneal wedge resection, and Bruce disease. Here are my references. Thank you.
Thank you so much, Dr. Kshitij, for making this complex astigmatism, making it so simple. Thank you so much. Now the topic is open for discussion. Dr. Manav. You are not audible.
Sorry, ma'am. Nice presentation, Dr. Kshitij. I have no questions to you. Nice presentation.
Dr. Shweta.
Dr. Kshitij, it was a very nice presentation. For LRI, limbal relaxing incision, which nomogram do you use? Which, any nomogram that is used for this much of astigmatism this length of incision needs to be made, or there is nomogram for it?
No, ma'am, I don't think. Sorry.
They are fixed on internet. You can find multiple LRI calculators,
Okay.
and the nomogram that we normally use is this is known as it will depend upon which type of astigmatism it is, and according to the astigmatism we give incision. That is the Napa nomogram, Nickem, egg and pack adjusted nomogram. That is a Napa nomogram that is normally used, and we can put it in our clinic, and according to the astigmatism we can put the millimeters of incision according to it.
Okay. Thank you.
Dr. Rakesh.
Very nice presentation. So my question is, when the axial length is less than 20 mm, so this formula is better for the IL calculation.
I think offer Q is preferable formula for IOL calculation.
Upper Q and any other?
Sir,
Polade 2.
okay, sir.
And how will you actually calculate the surgical induced astigmatism?
Sir, surgically induced astigmatism, sir, we need to have sir K1 and K2 values. IOL surgically induced astigmatism calculators available, in which typically age of the patient is needed and the length of incision is input, and it should be, I think, less than 0.5 or 0.3 to be a very good result for surgically induced astigmatism.
So what are the factors actually affecting the astigmatism? What are the factors actually you mentioned in the PPT also?
Please.
So what are the factors?
Sir, first of all is the age of the patient, sir. And then as soon as the age grows up, sir, eyelid pressure because the residual muscular contracture causes, sir, with the rule astigmatism. And other things are, sir, coexisting pathologies like pterygium is there, sir. So growth of pterygium, sir, is like variably affect astigmatism. So like if it is atrophic, it will cause the pulling of the cornea in that plane, and if it has a nodular lesion, sir, it will cause the compression. It might cause, sir, flattening on the vertical plane and compression on the horizontal planes. So against the rule astigmatism it can. And same way, sir, all the surgeries which have incisions on the cornea causes relaxation on that meridian. So wherever the incision is, after healing, sir, it causes flattening of the meridian. It can cause astigmatism in that plane.
Okay. Okay, thank you.
Dr. Pankaj.
When you are doing pterygium surgery, then astigmatism is bound to occur. So is there any difference in the method which you use which gives a minimal astigmatism? Which surgery should be done for pterygium excision?
Sir, conjunctival autograft, simple pterygium excision.
There is no difference when you do with the glue or the conjunctival autograft. They are better than Bayer's sclera, but amongst all other methods, it is the astigmatism is same.
Okay.
Thank you, judges. Thank you, Kshitij. Now we move on to third presentation by Dr. Simar Kalra. The mentor is Dr. Manoj Mathur, and presentation is on toric IOL. Dr. Simar, you can unmute yourself.
Good afternoon, ma'am. I'll just share my screen.
Sure.
Is the screen visible?
Yes, you can start.
Good afternoon, seniors and all the consultants. I'll be presenting my topic on toric intraocular lens. In addition to correcting the profound spherical error, the astigmatic component must also be corrected. Toric IOLs are the procedure of choice to correct corneal astigmatism of 1.5 diopters or more. It was first introduced by Shinsu et al. These are the available toric IOLs. The standard toric IOLs that are available in cylindrical powers of 1.5 diopters to 6.6 diopters. The best IOL material for toric IOL is hydrophobic acrylic, and the available IOL diameter is 11 to 13 mm. The patient selection should be done on basis of comprehensive ocular examination to rule out any ocular comorbidities. Cases with corneal scars or ectatic disorders are not ideal candidates for toric IOL implantation, and patients should want spectacle independence. Keratometry estimation is of paramount importance to determine the power as well as the axis of the toric IOL. Various instruments that help with it are manual keratometers, slit scanning systems, Scheimpflug imaging systems, OCTs, etc. The Scheimpflug principle-based instruments like Pentacam, Galilei are the ones which can tell about the posterior corneal curvature measurement. To avoid any inaccurate outcomes, most surgeons will compare the data from at least two independent measurements to examine for consistency. It is essential to evaluate the posterior corneal astigmatism and surgically induced astigmatism. For SIA calculation, we can use sites like drhill.com, which and fill it with 20 to 30 cases, be precise about the axis and the incision, and the calculator will auto-calculate the SIA. Various formula and toric calculators are available for IOL power calculation, which determine the axis as well as the magnitude of the toric IOL to be implanted. The ideal formula should take account the SIA, the posterior corneal curvature, as well as the effective lens position. The Barrett toric calculator takes into account both the ELP as well as the posterior corneal astigmatism and has better predictability than Baylor nomogram as well as Holiday and Alcon toric calculators. Here is an example of Acrysoft toric IOL calculator. The data that needs to be input are patient data, keratometry, IOL spherical power, surgically induced astigmatism, and incision and location. The output that we get is the recommended IOL model and spherical equivalent power, optimal axis placement, magnitude, and axis of anticipated residual astigmatism. Accurate alignment of toric IOL is a prerequisite to achieve successful outcomes. Various methods are iris fingerprinting techniques, image guiding systems, intraoperative aberrometry-based methods. Reference marking should be performed in an upright position in order to prevent cyclotorsion, which can be up to 28 degrees and has been observed in 68% cases. There are 4 different marking techniques: coaxial slit beam, bubble marker, pendular marker, tonometer marker. The reference marks are commonly placed in 3 o'clock, 6 o'clock, and 9 o'clock positions to improve predictability. Alcon's varied digital marker help with the axis marking. They use the high-resolution preoperative image and intraoperative registration to guide toric IOL alignment without the need of preoperative ocular marking. The toric IOL can be aligned along the appropriate axis guided by the digital overlay. Here is a screenshot of Virion digital marker. Just like the Alcon's Virion marker, the Callisto of disease is a similar modality. In cases with manual marking, the target axis is marked at the beginning of surgery after aligning the preoperatively placed reference marks with the Mendes degree gauge. While surgery, we have to take care of well-centered circular continuous capsular rexes. Providing adequate IOL coverage of around 0.5 mm is essential to ensure IOL stability in the post-operative period. First, gross alignment is achieved by rotating the IOL while it is unfolding. The IOL should be left about 3 to 5 degrees anti-clockwise of the final desired lens position. Final alignment should be done after complete OVD removal and hydration of the wounds. Post-operative outcomes can be assessed in terms of anatomical outcomes such as precision and stability of IOL alignment, and functional outcomes such as visual acuity and quality. Here are the visual and anatomical outcomes. Spectacle independence for distance vision has been reported in 60 to 97% of patients with toric IOLs. The complication that can occur is if 1 degree of misalignment is there, it can cause about 3% of the effective cylindrical power, and the entire toric effect is lost in cases with degree of misalignment. Realignment in cases of a 10-degree misalignment should be done. Conclusion is these days cataract surgery is equivalent to refractive surgery as the patient expects complete spectacle independence. If only the spherical component is corrected, the residual toricity will lead to spectacle dependence and reduced quality of vision. Therefore, toric IOLs should be implanted in all the patients with astigmatism of 1.5 meters or more. Thank you. These are the references.
Thank you, Simar, for wonderful presentation on a toric IOL, and you have in nutshell given all the important points, the biometry and the placement, which is the key factor, as well as the pre-op marking. But then Virion allows us to do it without that. So that's a good thing. Now with that, the topic is open for discussion. Dr. Pankaj.
What is the pre-operative workup you have told about? What is the iTrace system? iTrace?
Sir, iTrace system is intraoperative. It's a barometric iTrace system. Sir, it allows us to do the marking intraoperatively when the patient is aphakic. In that terms, the reference, the astigmatism is calculated perfectly because the patient is aphakic and there is no lens astigmatism present. And
it is a combination of both the Placido-based corneal topography and the aberrometry, so as to calculate the exact power.
Thank you, sir.
Dr. Rakesh.
So very nice presentation. So my question is, what is the role of posterior astigmatism for the eye calculation?
So posterior curvature of cornea's astigmatism is as important as the anterior curvature because the rays of light are the refraction of light depends equally on the posterior curvature as in the anterior curvature. First, previously it was not taken into account, but it now is studied that about 1 to 2 diopters difference can be made if posterior curvature is not taken into account.
Okay, so if the anterior astigmatism with the rule, so threshold of the toric IOL is increased. So if it is the ATR, threshold for the toric IOL is decreased. So why this region is very important? Because the posterior corneal surface is always against the ATR actually. Okay, thank you.
Thank you, sir.
Thank you. With this, we move on to another presentation by Dr. Shivangi Sahu. The mentor is Dr. Shubhra Mehta, and she will be presenting on BRVO.
Good afternoon, everyone. Am I visible?
Yes, you can start.
Good afternoon, everyone. I'm Dr. Shivangi Sahu. My topic for presentation is branched retinal vein occlusion. Retinal vein occlusion is the second most common retinal vascular disorder after diabetic retinopathy. It can be divided into CRVO, hemi-BRVO, and BRVO. BRVO is venous occlusion that occurs in any of the branches of the central retinal vein. It affects male and females equally, mainly diagnosed in the supratemporal quadrant of the retina, and classical risk factors are hypertension followed by dyslipidemia, and less commonly encountered, which are mainly seen in young patients, are hyperhomocystinemia and antiphospholipid syndrome. Then pathophysiology, there occurs atherosclerosis of artery, which leads to compression of vein at AV crossing, which further leads to occlusion of vein, and which leads to turbulence of flow. Then finally, endothelial cell damage occurs, which finally leads to thrombus formation. Then pathogenesis are multifactorial. Then arteriovenous crossing. Koyanagi mainly found retinal artery and veins shares a common adventitia which predisposes to occlusion. Zhao et al. Found the artery anterior to the vein at the obstructive site in 99% of the affected eyes. Degenerative changes. Jeffries et al. Showed that expected venous compression at AV crossing does not exist. Seeds described alteration of venous endothelium and intima media as a root of pathogenesis of BRVO. Then pathogenesis of macular edema, retinal vein occlusion, which leads to retinal capillary damage and which will lead to hypoxia. Then it will release inflammatory cytokinins and VEGFs, which finally leads to breakdown of inner blood retinal barrier. And there occur increased vascular permeability and vascular leakage, which leads to macular edema. Then clinical features, symptoms are sudden painless loss of vision, signs, intraretinal hemorrhage, macular edema, dilated tortuous veins and cotton wool spots, acute BRVO, intraretinal hemorrhage in a wedge-shaped pattern, the occluded vessels, cotton wool spots, dilated tortuous and occluded vein. Chronic BRVO, we can see vascular sheathing, collaterals, hard exudates, cystoid macular edema. Complications, chronic macular edema followed by epiretinal membrane, hard exudates, neovascularization, retinal detachment can occur. Investigation in young patients, we should ask history of oral contraceptive pills, and we should rule out infectious causes. In older patients, cardiovascular workup should be done in all patients. Then fluorescence angiography, it will macular leakage, edema, macular ischemia, large segment of capillary non-perfusion. Findings can be delayed filling of occluded retinal vein. We can find collateral vessels, diextravasation from macular edema, or retinal neovascularization. Then block fluorescence from intraretinal hemorrhage in acute stage, 6 months later hemorrhage have cleared. Then this is the fundus photograph and fluorescence angiogram showing collateral vessels, which can be confused with neovascularization, but they do not leak on fluorescence angiography. Then OCT, it can measure macular edema and monitor the response to treatment. We can see cystoid macular edema, subretinal fluid. In chronic cases, we should look for photoreceptor, inner segment, outer segment junction abnormalities. Then spectral domain OCT, various modalities available for management. First is laser treatment. It is mainly of two types, grid laser and scatter. Then grid pattern, duration 0.1 second, a 100 micrometer diameter spot size. Then BUA study is done for macular edema. Result, scatter argon photocoagulation prevents the development of neovascularization and vitreous hemorrhage, but should be applied after development of neovascularization. Then laser treatment, first is showing grid laser pattern, second is showing peripheral scatter photocoagulation. In anti-VEGF treatment, they are the treatment of choice for BRVO. Then ranibizumab and bevacizumab, the duration of action for both of them are 4 weeks, same, while aflibercept 4 to 8 weeks. Ranibizumab and aflibercept are FDA approved, while bevacizumab it is used off-label. Then first is ranibizumab Lucentis. Bravo study is done. Ranibizumab provided rapid and effective treatment for macular edema following BRVO with good safety. Relate study, no long-term benefit in BCVA resolution of edema or number of ranibizumab injection obtained by addition of laser treatment. Brighter study is done for ranibizumab monotherapy versus ranibizumab versus laser alone. It concluded that ranibizumab also provides superior result compared to laser alone. Horizon study is done for ranibizumab treated groups had early resolution hemorrhages. P10 study is done for ranibizumab. Then Comrade B, ranibizumab versus dexamethasone implant at 6 months, ranibizumab has better visual outcome. Then aflibercept Vibrant study was done. In this intravitreal injection, 2 mg injection every 8 weeks showed good control of macular edema. In bevacizumab Avastin, Burwald study was done. They concluded that overall mean change in BCVA treated with 1.25 mg was better with no significant adverse events. Then intravitreal triamcinolone acetinoid, in this core study was done, which was mainly standard care versus corticosteroids. They concluded that grid laser photocoagulation is better than IVT in macular edema secondary to BRVO. Then dexamethasone intravitreal implant Geneva study was done. The study demonstrated that this slow release device helped achieve more than 15 letters improvement in BCVA in a significantly less time than sham group. The major side effects were IOP spikes and cataract progression, indications of intraocular steroids, treatment failure with anti-VEGFs, patient with recent major cardiac events, then unwilling for monthly injections. Past planar vitrectomy can be done. Advential schistotomy, now it is obsolete. Conclusion, BRVO is the second most common vascular pathology, hypertension most common risk factor, macular edema most common cause of visual loss, and anti-VEGFs are the first line of treatment for macular edema secondary to BRVO. These are my references. Thank you.
Thank you, Dr. Shivangi, for a wonderful presentation on BRVO. What is the association of BRVO and glaucoma?
Ma'am, actually, neovascularization.
Stop sharing your screen. Yes, now.
Ma'am, actually, BRVO, if neovascularization occurs, it will lead to rise in intraocular pressure, neovascularization of iris or angle, it occurs in very rare cases, but less percentage is there, but it can occur, and due to neovascularization, it will lead to glaucoma.
So it is more common in glaucomatous patients. So you should see the disc carefully, and not only this eye, the other eye also.
Yes, ma'am.
Dr. Mana?
Yeah, Dr. Shivangi, nice presentation. Also to your moderator, Dr. Subra. Just one question, Dr. Shivangi. What are the systemic risk factors enlisted in association with the branched retinal venous occlusions? Can you name a few systemic factors associated?
Yes, sir. So most common risk factor, systemic hypertension, followed by dyslipidemia, then hypertension, dyslipidemia, or ocular hypertension, glaucoma, high BMI, body mass index. Then, sir, less commonly encountered, we can see thrombophilic disorders like sir, hyperhomocystinemia, which can be seen in young patients, and antiphospholipid antibody, anticardiolipin antibodies.
Nice, good. And how will you diagnose by seeing fundus picture that this is patient of branched retinal venous occlusion? Can you enlist a few features that you will see?
Yes, sir. Actually, BRVO is a clinical presentation. We can mainly look, sir. It will present in one quadrant, and we can see the flame-shaped hemorrhages in one quadrant, and we can see the occluded vein. Distal to the vein, it is dilated, and we can see soft exudates and hard exudates if it is chronic, and macular edema.
Which quadrant is it more commonly found in?
Sir, supratemporal quadrant is more commonly seen because sir, the AV crossing are more.
That's it. Nice. Very well answered.
Dr. Shweta?
Actually, everything has been covered. No question.
Okay, thank you, Shivangi. With this, we complete our Ujjain division competition. So judges, please mark that Ujjain division out of 4, we have to give one finalist. So with this, now we move on to Indore division, and I would like to thank Dr. Shubhra and Dr. Manoj Mehta sir from Ujjain for giving such wonderful presentations along with their PGs. Thank you so much. Indore, now Dr. Shubhra is going to judge. So Dr. Shweta, you just keep a watch on time, please. So the first presentation from Indore division is Dr. Trisha Yadu. She's from MGM, and Dr. Shweta is mentor for her. And again, the presentation, I think glaucoma effect persists for 12 to 18 is an ocular hypertension. So let's start. Dr. Trisha, please.
Yes, ma'am. Ma'am, I hope my screen is visible.
Perfect. Start.
Good afternoon, everyone. Today is my talk on ocular hypertension and the guidance of Dr. Shweta Walia, ma'am. Ocular hypertension affects 4 to 10% of the population, which is older than 40 years. It is 10 to 15 times more prevalent than primary open-angle glaucoma. In southern India, prevalence of 1.1 has been reported. In Western countries, incidence is 5 times higher in blacks than in white. Now, what is actually ocular hypertension? It is an intraocular pressure of more than 21 millimeters of mercury in one or both eyes, as measured by applanation tonometry on 2 or more occasions, with absence of glaucomatous defects on visual field testing and normal appearing optic disc and nerve fiber layer. It also includes anatomically normal open angles on gonioscopy, absence of ocular condition that contributes in any rise of intraocular pressure. It is an idiopathic condition. In many patients, myocilin gene mutations have been found. Now, how do we identify such patients? We have to take a proper history of such patients to rule out any secondary cause like trauma or steroid usage. We have to take history of hypertension, the medications the patient is using, diabetes, spectacle usage to rule out myopia, any positive family history, severity in the first degree relatives. And we also have to subject the patient to a thorough slit lamp examination to rule out any presence of any microcystic edema, Krukenberg spindle, keratic precipitates, iris atrophy, synechiae, rubiosis, ectropion uvea, iris bombay, and differentiation in iris coloration.
The dilemma many clinicians face is whether to treat these patients or not. The answers were given to us by ocular hypertension treatment study, in which the patients were divided into two groups. The first was medicational group, in which the topical treatment was given to lower the IOP by 20%. Second was observational group, in which no topical treatment was given. Now, what were the results of this study? At 5-year follow-up, they saw progression of primary open-angle glaucoma to 9.5% in observation group and 4.4% in treatment group. There was a 22.5% reduction in IOP in the treatment group. There was another study done to assess the role of retinal nerve fiber layer using OCT, in which the patients were divided into three categories: ocular hypertensive, normal, and glaucomatous eyes. The results of this study was RNFL was significantly thinner in ocular hypertension eyes than in normal eyes in inferior and nasal quadrants. Now, when do we treat such patients? Considering low rate of progression to primary open-angle glaucoma, the cost of ocular hypotensive, long-term compliance, and side effect of the drugs, not every case of ocular hypertension is subjected to treatment. Treatment is only recommended in high-risk groups. This is a risk calculator which was developed by Medeiros and colleagues, which calculates the probability of conversion of a glaucoma suspect into a glaucoma patient. Now, who requires an immediate treatment? These are the patients who show RNFL defects, parapapillary changes, intraocular pressure of more than 30 millimeters of mercury, or pressure of more than 26 millimeter with central corneal thickness less than 555 microns, vertical CDR of 0.4:1 or more with central corneal thickness of less than 555 micron. Other categories: moderate risk, which require an annual follow-up, and low risk category requires a 2-yearly follow-up. Other possible indication for treatment are one-eyed patient, patient willing for treatment, young patient, unreliable visual optic disc assessment, or vascular occlusion in other eye. How do we treat these patients? We will target IOP lowering by 20%. The preferred agents of treatment are prostaglandin analogs. Monotherapy is preferred. If medical treatment fail, we can do SLT. This is a study called as LIGHT trial, which shows the effect of selective laser trabeculoplasty on ocular hypertensive and open-angle glaucoma. My take-home message from this talk will be: thorough clinical evaluation in a patient with raised intraocular pressure is important, and we have to subject these patients to a careful monitoring. We have to take into consideration patient preference and decisive factor. Key point to consider is age, therefore the life expectancy. The decision to treat is not straightforward and has to be made on individual basis. Thank you.
Thank you, Dr. Trisha, for a wonderful presentation. What are the risk factors for developing ocular hypertension?
Ma'am, first of all, the most important risk factor in developing any glaucoma would be the intraocular pressure. Second, the central corneal thickness was also an important factor. Positive family history in close relatives, vertical cupping of more than 0.6:1, and yes, ma'am, these were the myopes, also hypertension.
So CCT is an independent risk factor.
Yes, ma'am.
Thank you so much. Dr. Pankaj, you want to ask any
Which
question?
method is better for measuring the corneal thickness in such patients?
Sorry, sir.
How will you measure the corneal thickness?
Sir, using pachymetry.
Pachymetry by what? ASOCT or B scan?
The ASOCT is better.
Is more accurate. How much is the thickness normal?
Sir, 560, above 560.
So what is the correlation? When it is thick, then what happens?
Sir, if it is a thick cornea, overestimation of intraocular pressure occurs.
Dr. Shubhra?
Very nice presentation, Trisha. You covered all the points very nicely. I have one question. Along with raised IOP, which is the risk factor which is associated with the highest risk of progression to POAG in a patient of ocular hypertension? And what are the approximate percentages according to the ocular hypertension treatment study?
Ma'am, in OHTS, mostly two independent risk factors were found. First was intraocular pressure, second was central corneal thickness.
Yes. How were they correlated with one another?
Ma'am, almost 9.5% patient who had raised intraocular pressure, they were found to be converted to open angle glaucoma in a span of 5 years.
Okay, it was seen that if a patient is having an IOP more than 26 of Hg, but the central corneal thickness is more than 588, then the risk of progression is only 6%. On the other hand, with an IOP more than 26, if the central corneal thickness is less than 555, then the risk of progression is more than tripled, it is 36%. So central corneal thickness is a very important risk factor along with raised IOP.
Yes, ma'am.
And it also affects the decision to treat.
Yes, ma'am. Thank you, ma'am.
I have
When
one
will
more
you treat
question.
Sorry,
Ma'am,
Please,
please go
Chopra,
on.
continue.
I just wanted to ask you a very basic question. How will you do diurnal variation? Would you like to do diurnal variation in these patients?
Ma'am, actually, diurnal variation has been studied. There is only one important thing we can do with diurnal variation. That is, we can decide the timing of dosage of the drugs for the patient. Rest, it has no significance as such, because through medical treatment, we cannot change the diurnal pressure of the patient, diurnal variation in the pressure.
Okay, how do you measure the diurnal variation?
Ma'am, we cannot do it in clinics because it is usually highest at 7 a.m. in the morning and decreases in evening. So we can give handheld tonometers to the patient and measure accordingly.
Actually, the ideal way is 24-hour IOP monitoring, which is not practically feasible. So these days, office diurnal variation is being practiced, that you measure it from 8 a.m. to 8 p.m. Basically, the peak coincides with the morning rise of IOP, we all know. So the early morning readings should be taken possibly. Or another method is that you ask the patient to come on different days at different times to your clinic, so that you have an idea of the IOP at different times during the day.
Okay.
That is how in the current practice we measure the diurnal variation.
Thank you, ma'am.
Thank you, Dr. Trisha.
Thank you, Dr. Trisha and judges. Now we move on to our second presenter from Indore, Dr. Rakshit Agrawal. Mentor is Dr. Bhaisare, and he will be presenting on the FLAC, which is femtosecond laser assisted cataract surgery.
Yes, ma'am. Is my presentation visible?
Not yet.
Is the presentation visible now?
Yes, you can start, Rakshit.
Good afternoon, everyone. Today's my topic for presentation is femtosecond laser assisted cataract surgery. The learning objectives for today's session would be femtosecond laser, its components and instrumentation, the surgical procedure, the advantages and disadvantages. Then we'll be seeing some challenging cataracts where FLACS is very important, and other uses of femtosecond lasers. Femtosecond is a solid state laser that emits ultra short pulses in near infrared range in the domain of femtoseconds. It works on the principle of photo disruption, and it was FDA approved in 2010. Actually, it is very similar to ND-arc laser, but the only major difference being that the application of this laser is an ultra short laser pulses that causes the collateral damage to be within 1 micron, and there is no surrounding heat damage to the tissue, and and precise cuts can be obtained on any tissue like cornea or lens. The mechanism of photo disruption is a pulse of laser energy is focused to a precise location inside the cornea that creates a microplasma vaporizing approximately 1 micron of the corneal tissue. An expanding bubble of gas and water is thus created, separating the corneal lamellae. Thousands of such laser pulses are connected in a linear pattern to form a resection plane, which can be either horizontal, vertical, or angled, thus causing a perfect cleavage of the cornea. There are three components of any femtosecond laser system. The first is patient interface, imaging system, and the laser delivery. Patient interface. This is the most important because it acts as a coupling device between the laser machine and the eyeball. It helps in delivery of the laser and maintains the positional and mechanical stability of the eye. Imaging system. Every femtosecond laser system is associated with a 3D spectral domain OCT. On the image, we can see the corneal thickness as well as the lens thickness and the anterior chamber angle, and we can plan the incision accordingly. Laser delivery. First of all, capsulotomy is created, and after that, the femtofragmentation of the lens is created, and on the last, the corneal incisions are made and the arcuate incisions are made. The surgical procedure consists of the two parts, femtosecond laser part and the manual part. In the femtosecond laser part, there is docking, planning, capsulotomy, lens fragmentation, then corneal incisions. And in manual part, the incisions are opened, OVD is injected, the entry capsule is removed, hydrodissection is done, and the routine phaco is done. Docking, the most important step in docking is corneal centration, because the corneal centration affects the corneal incisions, the arcuate incisions, and the capsular axis. The quality of image is reduced by any corneal pathology or any corneal folds that occur during docking. Planning of incision is then done according to the preoperative corneal astigmatism. The capsular axis and lens fragmentation is also planned. The axis is always made first before lens fragmentation because gas bubbles are created that can obstruct the laser delivery, can increase the intralenticular pressure, and distort the rhexis plane, leading to incomplete rhexis. This is a photograph showing a complete rhexis in mature cataract and avoiding any Argentine plaque sign. Lens fragmentation can be customized as suited to the surgeon. In soft cataracts, generally concentric pattern is used as in the above picture, and grid pattern is used in harder cataracts. The corneal incisions are watertight and accurate, and you can see in the above two images there is accurately formed triplanar incisions. Then the manual part, the patient interface is removed and the patient is shifted to OR. The corneal incisions are dissected by spatula. So first of all, we should look for the completeness of capsular axis, and if a free floating axis is found, it is removed with the help of forceps. Complications, machine-related complications like error in software can occur. Subconjunctival hemorrhage, pupillary constriction, and incomplete capsulotomy can occur. The absolute contraindication for this procedure is small palpebral aperture, neck and back problems, as well as nystagmus, patients with glaucoma and retinal diseases, corneal opacities which hinders the laser delivery, and small pupil less than 5 millimeters. The advantages of this procedure is it has a greater reproducibility and stability with the incisions, reduction in the effective phaco time by approximately 30%, and phaco energy during phacoemulsification is less, thereby leading to less endothelial cell damage. Posterior axis can also be done, and less macular edema after surgery. The challenging cases like posterior polar cataracts, very precise capsulotomy helps in adequate sulcal support. If in cases of posterior polar cataracts, the posterior capsular dehiscence occurs. It has an inbuilt OCT that can help in demonstrating pre-existing capsular defects. Also, the femtofragmentation of the lens helps in less manipulation during phaco. Also, in hypermature cataracts, subluxated lens, and zonular weaknesses, flex is advantageous. Other uses of femtosecond lasers can be in presbyopic correction, creating corneal flaps and refractive surgeries, as well as dissecting the corneal tissue from the recipient, from the patient in corneal surgeries, and penetrating keratoplasties. The major disadvantage of the surgery of femtosecond laser is cost. If the cost can be reduced, we can use flex for every cataract surgery in the future. Also, training of staffs, operating room logistics, operating time, and increased patients' expectations. Thank you.
Thank you, Dr. Rakshit, for perfect presentation of
Thank you,
Dr. Pankaj.
It is very costly and precise surgery to go for. You have mentioned the contraindications, but what are the relative contraindications? Contraindications where this surgery should not be performed or performed with caution?
So relative contraindications are in patients of glaucoma. There are very high chances of raised IOP. Also in in retinal diseases, also it is a relatively
cornea is more important. If there are corneal dystrophies, pannus,
yes,
ocular surface diseases, This should be avoided in this case. Otherwise, there will be problem. Or the patient is having tremors, dementia, because here stability of the patient is very
Patient
important.
is less.
So cornea is very important to look for repeated epithelial corneal erosions, dry eye. This should be taken care of first.
Okay.
Dr. Rakesh, you want to ask something?
So very good presentation actually. And my question is that when you compare the conventional phacoemulsification with flex, so what is the additional advantage actually to do the flex or conventional? What is the actually when you compare the complications or when you compare the astigmatism? I think when we see the study, both are the comparable. So what
So
are
on day
the
one, on post-operative day one, there is, according to the studies on post-operative day one, there is decreased corneal edema and less anterior chamber reaction. But after 3 months, the results are comparable only.
So what are the additional advantage? Why I saw the when you actually depend on the flex, the surgical skill of the surgeon also reduce, I think.
Yeah. So, sir, in nowadays in NS grade 1 or 2 cataracts, patients are operating very early. So in those cases, we can actually have aim on zero effective phaco energy used. As in softer cataracts, the after phacopigmentation, after femtopigmentation, the only aspiration can be used to extract the cataract.
But in the case of the subluxated cataract, I think the flex is the better than conventional because
Yes,
sometimes when you make accurate
Rexis is very difficult in
yeah,
to make in subluxated cataracts and zonular weaknesses.
Okay.
Thank you, judges and Rakshit. Now we move on to
Thank you, ma'am.
presentation. Dr. Sakshi Tiwari, she will be presenting on phakic IOLs, and she's from MGM, and the mentor is Dr. Shweta Walia. Dr. Sakshi, please.
Yes. May I interrupt? Mentor is Dr. Preeti Rawat, madam.
Oh, sorry. Yes. मैंने नीचे वाला पढ़ लिया है.
बात है मैडम.
हाँ, दोनों एक ही है. नहीं, but the Preeti is also there, ना. We should acknowledge Preeti also.
Good afternoon, everyone.
You can make slideshow. Perfect.
Good afternoon, teachers. My topic for today's talk is on phakic intraocular lenses. What is a phakic IOL? A phakic IOL is an artificial lens implanted in the anterior or posterior chamber of the eye in the presence of the natural crystalline lens to correct refractive errors. Phakic IOLs are an evolving technique in the field of refractive surgery. Although patients with high myopia constitute only about 2% of the myopic population, 13 to 15% of patients presenting for refractive surgery belong to this group. LASIK is justifiably still the most widely practiced modality of refractive surgery because of high level of comfort, quick recovery, stable predictable results, and ability to perform bilateral treatment in one sitting. But when it comes to higher grades of refractive errors, it has the following limitations: significant residual error, loss of best spectacle corrected visual acuity, risk of iatrogenic corneal thinning, induction of tear film abnormalities, induction of higher order aberrations, and poor contrast sensitivity. Disadvantages of phakic IOLs in high refractive errors include preservation of corneal architecture, preservation of accommodation, predictable refractive results, predictable healing, rapid visual recovery, stable post-op refraction, reversible and adjustable, cheaper, and techniques similar to that of phacoemulsification. The following options are available in phakic IOL: anterior chamber angle supported, anterior chamber iris fixated, and posterior chamber IOLs. These are some of the examples of all the three categories. The general criteria for implanting a phakic IOL includes stable refraction of less than 0.5 diopter change for 6 months, clear crystalline lens, ametropia not suitable appropriate for excimer laser surgery, unsatisfactory vision or intolerance to contact lenses or spectacles, an anterior chamber depth greater or equal to 3.2 mm for iris, claw lens, and angle supported phakic IOLs, and 2.5 mm for posterior chamber IOLs, and a minimum endothelial density following the below mentioned parameters, and no ocular pathology. Contraindications include active disease in the anterior segment, ACD of less than 2.5 mm, corneal dystrophies or decreased endothelial cell counts, clinically significant cataracts, presence of anterior or posterior synecdoche, pre-existing macular pathologies, and systemic disease. Pre-op assessment for phakic IOL include refraction, unaided and BCVA, anterior and posterior segment evaluation, ACD from corneal endothelium, corneal topography, intraocular pressure, white-to-white measurement, and corneal endothelial cell count. PAR calculation for phakic IOLs. The essential parameters include refraction at the 12 mm spectacle plane or vertex refraction, keratometric dioptric power at the corneal apex, AC depth, horizontal and vertical radii of curvature of cornea, white-to-white measurement for the length of IOL. Manufacturers provide with specific nomograms for IOL planned for surgery. The ICL overall diameter depends on the ciliary sulcus diameter. It should provide perfect stability with no excess compression forces to the sulcus and allow correct vaulting. Excessive vaulting can lead to pupillary block, whereas insufficient vaulting can lead to cataract. Anterior chamber iris claw lens. The iris claw lens artisan is a single-piece non-foldable IOL made of perspex, a UV light filtering PMMA material, which is available for correction of myopia, hyperopia, and astigmatism, as well as for secondary IOL implantation in aphakia. The following posterior chamber phakic IOLs are commonly in use: silicon, which are PRL phakic refractive lenses, Collamer ICL, hydrophilic acrylic stick lens. The implantable Collamer lens ICL is currently the most widely used posterior chamber IOL. In 1993, a posterior chamber IOL made of hydrophilic flexible material Collamer was developed, which was a copolymer of HEMA and porcine collagen. Its characteristics include high biocompatibility and gas permeability, presence of metabolite free space between the IOL and the crystalline lens, which retards the development of cataracts, deposition of a monolayer of fibronectin on the IOL surface, which inhibits aqueous protein binding and makes the IOL invisible to the immune system. This is the current model in use. Phakic refractive lenses PRL is a hydrophobic silicon single-piece plate design IOL with a refractive index of 1.46. Mechanical touch, impermeability of nutrients, and stagnation of waste metabolites in the aqueous causes increased risk of cataract formation. Changes were also made in its vaulting to avoid this complication. This is the model used in PRLs. The complications of phakic IOLs include IOL decentration, endothelial cell loss, pupil ovalization or iris retraction, pigment dispersion glaucoma, chronic inflammation uveitis, pupillary block glaucoma, cataractogenesis, and other anesthesia-related complications. Role of iridotomies. Single or multiple peripheral iridotomies may be done to reduce the risk of pupillary block and its consequences. Also, implantable phakic Collamer lenses are a type of ICLs made of hydrophilic acrylic material which can correct myopia up to -30 diopters. There is a special IOL hole for better aqueous circulation and decreased risk of cataracts. There is a patterned hole in the upper left corner to ensure proper direction of lens in the cartridge and while unfolding. Better long-term stability and suited for young patients, affordable, and also available as toric IOL. Thank you.
Thank you, Dr. Sakshi, for compilation of ICL, which is used for high myopes. Dr. Shubhra, can you ask something?
A very nice presentation, Dr. Sakshi. You have presented all the points very well. I just want to know, can you use an ICL in a case of keratoconus?
Yes, ma'am. ICL can be used in patients with thinned corneas. In fact, it is indicated in patients with thinned out corneas. But the problem is that the corneal topography is not very well. Corneal thinning is more in the central part and less in the peripheral part. So vaulting may sometimes differ in keratoconus patients. Otherwise, ICL can be used in keratoconus.
Can it be used in all patients of keratoconus or only in some patients of keratoconus?
Ma'am, if only the central thinning is more, only in the optical zone the thinning is more, then ICL can be used. If the thinning is more even in the peripheral cornea, then I think it will pose a problem in this while implanting it in the ciliary sulcus.
Okay, in keratoconus patients, if there is a central cone and the vision is improving well with glasses, only then you can use an ICL. And the patient is not needing contact lenses for vision improvement. On the other hand, if the cone is eccentric, as you said, there is peripheral thinning, or the vision is improving only with rigid lenses or the rose-K lenses, then these patients should not undergo an ICL procedure. So keratoconus patients who are not suitable for any other kind of surgery can undergo, in some special conditions, they can undergo an ICL implantation. Thank you, Sakshi.
Dr. Manav? Dr. Manav?
Nice presentation, Dr. Sakshi, and to your moderator, Dr. Rawat. No questions to you. Nicely presented.
Thank you. Thank you so much. I think we move on to next presenter, Dr. Rishabh Khare. Mentor is Dr. Shweta Walia, and he will be presenting amblyopia diagnosis and treatment.
I would highlight that he is a first year resident and he has joined a few months back only.
Oh.
And by luck, he got 2 months time. Otherwise, he also had to present in the month of January.
Yeah, I was seeing like last time we had 7 presenters from Indore, and this time 8 presenters. So out of 15, 1 selection.
Ma'am, shall I start?
Yes, Dr. Rishabh, please do the favor.
Good afternoon, everyone. The topic I'll be presenting today is amblyopia diagnosis and treatment. I have been mentored by Dr. Shweta Walia, ma'am. As you can see, the sentence before you is very apt for amblyopia. The doctor sees nothing, the patient sees nothing. The diagnosis is amblyopia, as was given by Hippocrates in 450 BCE. Now, amblyopia in Greek stands for dullness of vision. Decrease of visual acuity caused by abnormal binocular interaction occurring in one or both eyes as a result of patterned vision deprivation during the critical period, for which no cause can be detected during the physical examination and which in appropriate cases is reversible by therapeutic measures. The American Academy of Ophthalmology considers amblyopia an intraocular difference of 2 lines or more in a visual acuity table. Now, amblyopia can be classified into anisometropic amblyopia, which can be due to myopia, hypermetropia, and astigmatism. It can be due to strabismus. It can be meridional amblyopia. It can be ametropic amblyopia, and it can be stimulus deprivation amblyopia, of which the cause are ptosis, lid masses, pupillary anomalies, cataract, and posterior chamber opacities. The classification of amblyopia severity based on the visual acuity is mild, moderate, and severe. Now, doing a workup for the case of amblyopia, the basic is history taking. In history taking, we will focus upon the points like family history of amblyopia, the developmental milestone, age at diagnosis, points to previous treatment taken, patching details, and patient compliance. Now, visual acuity has already been taken in the previous lecture, but one method which is very important for pre-verbal age group of children is the CSM method, where C stands for corneal light reflex, S for steadiness of fixation, M for maintenance of fixation. Amblyop shows crowding phenomena, where they have the inability to distinguish letters crowded together, but they can very easily say the single octotypes. Monoocular occlusion, as you can see in this video, when we try to occlude the sound eye of the patient, he or she resists that occlusion. There is Bruckner red reflex test, where we can see the eye with the amblyopic potential is fainter and has a fainter and duller reflex as compared to the normal eye. We can do the 4-diopter prism test, which is used to confirm or rule out the presence of small central scotoma. As you can see in the video, the eye which is not covered, if shows movement, the test is considered negative. And if the eye which is not covered shows no movement is shown, it is positive. We have to do cycloplegic refraction. Now, we'll do the motor evaluation of the patient for extraocular movements, ocular alignment, and prism bar cover test, which is done with glasses and without glasses. We can do the sensory testing for stereopsis by tests like Lang-2 pencil test, Worth for dot test, TNO test, and Randor's test. We'll see the fixation reflex of the patient, and amblyop shows eccentric fixation. They have a decreased contrast sensitivity. They have a decreased vernier acuity, decreased grating acuity. They show improved visual acuity with neutral density filters. The treatment options available for amblyopia are refractive correction, occlusion therapy, pharmacological treatment, optical treatment, Bangerter filters, and surgery. These are the guidelines for the refractive correction in infants and young children. Now, if we go for the treatment protocol, anisometropia can be treated by refractive correction and occlusion therapy. Strabismus can be treated by occlusion therapy plus surgery. The meridional amblyopia can be treated by refractive correction and occlusion therapy. The ametropic amblyopia can be treated by the refractive correction and occlusion therapy. And for stimulus deprivation amblyopia, we have to do surgery. Now, occlusion can be done by the following methods: micropore, contact lens occluder, bandage occluder, spectacle occluder, and patches. Now, going for part-time patching versus full-time patching, as shown by the PEDIC studies in amblyopia treatment studies, it has shown that part-time patching is as effective as full-time patching with greater patient compliance. Now, how to go about occlusion? The child and the parent should be motivated. Parents should be forewarned that the child will likely resist the patch. Active vision exercises by amblyopic eye should be done. The patients are re-evaluated at an interval of week per year of their life. Pharmacological penalization by 1% atropine can be done. We can use optical penalization. We can use Bangerter foils and filters. Now, coming to alternative therapy and recent advances, we have the vision therapy, which is intended to improve visual acuity and binocularity. Can be continued with home exercises. We have got liquid crystal glasses, which have better compliance, works on the principle of intermittent occlusion. We have got binocular therapy, in which high contrast image is given to amblyopic eye and low contrast image to the fellow eye. We got video games, which can induce cortical plasticity and improve visual function beyond the sensitive period of brain development. We can give transcranial magnetic stimulation, where electrical currents stimulate the cortical areas. We have got systemic pharmacological treatment, which have shown promising results in animal models of neurotransmitters like donepezil, fluoxetine, carbidopa, levodopa, and citicoline. Even adults can be treated for amblyopia, where we can use glasses and patching, and video games, which induces plasticity in the visual system of adults with amblyopia. With this, I would like to conclude my presentation. Thank you.
Thank you, Rishabh, for such an excellent presentation. It was very perfectly executed. Doesn't look like that you are a first year student. Well done. You have a bright future and you are in safe hands. What is the highest age till you can prescribe an occlusion, or what are the impact of occlusion when you do the patching till particular age? After that, its impact reduces.
Ma'am, till the 8 years of age, ma'am, the patching by occlusion can be given. And ma'am, as the age increases, the effect of patching decreases because the plasticity of the brain or the development of the eye system in the brain happens till the 8 year of age.
Okay, 8 to 9 years, and then maximum up to the 12 years, the results have been found to be better. After that, the results are lesser.
Yes,
Dr. Pankaj, you want to ask something?
Is there any medical treatment for this in adult amblyopia? Medical management?
The neurotransmitters have shown effective in animal models only, sir. But medical treatment has not yet started, as far as I know.
No, it is started. Levodopa and citicoline are the drugs to be given, but
Okay.
the results are not that promising. But citicoline is given in amblyopic patients.
Yes, sir. Yes.
Dr. Rakesh?
Very nice presentation. So, is there any surgical treatment for the amblyopia?
So, in stimulus deprivation amblyopia, we do surgical treatment, as in for cataracts and lid masses or pupillary anomalies, sir. But there's benefit and loss, sir, because in cataract, if the patient has cataract, the benefit of having an intact natural lens with its accommodative properties outweighs the benefit of removing and having a clear path for the eyes.
Okay, so think of it that there is, I think. They are the few treatment modality only. Okay.
Yes.
Okay, thank you.
Dr. Rishabh, nice presentation.
Thank you very much, sir.
What is this? What is dichoptic principle?
Sorry, sir, I don't know about dichoptic principle, sir.
No, you use the term contrast sensitivity being used to stimulate the eye with high amblyopia.
Yes, sir. The higher contrast images are given to amblyopia and lower contrast images are given to normal eye.
Yeah, that's what is dichoptic principle of treating amblyopia, by showing them with different contrast sensitivity.
Yes, sir. Yes, sir.
That's what is dichoptic principle, and it's used in a lot of these cloud-based softwares that are now available. One of them is iNotes, and it's being put to good use. That's the dichoptic. So
yes.
Very nice presentation, Rishabh. I must congratulate your mentor also, because for a first year student, you have made a very nice presentation.
Thank you, ma'am.
Can you tell me what is vernier acuity? You mentioned it in your presentation. How does it differ from Snellen acuity?
Ma'am, we give the patient a series of lines, ma'am. and we ask the patient to see whether he can see the contrast between one line and the empty spaces in between, ma'am.
Okay. Basically, you have to judge the offset or the misalignment between parallel lines.
Yes, ma'am.
How does it differ from Snellen acuity? What does Snellen acuity test and what does Vernier acuity test?
Ma'am, Snellen acuity test the angle from which the patient can identify, ma'am. That is for Snellen's acuity. And ma'am, for
okay,
ma'am, this is I know, ma'am.
Basically, Vernier acuity that relies heavily on cortical processing. So it is rather than optical media, it is more a measure of retinal and neural functions.
Yes, ma'am. Yes, ma'am.
So testing of both Snellen acuity as well as Vernier acuity is important in evaluating a patient of amblyopia. Thank you, Rishabh.
Yes, ma'am. Thank you, ma'am.
Wonderful presentation, Rishabh. Keep doing this. Now we will move on to another presentation from MGM, Dr. Krutika Frote, and mentor is Dr. Manushri, and she will be presenting on ocular findings of SLE. Is she here?
Yes, she was there. Krutika?
Because
hello. No, she is there. Krutika Thorat is there. And
she's there. She's there. Yes. Dr. Krutika? The screen is blank. Nothing shown.
I think she was there right from the beginning of the presentation.
Yeah, she's here. Krutika?
Yes, ma'am. Yes, ma'am. I'm here. Sorry, ma'am, for the network issues.
Okay, okay, no problem.
Is my screen visible?
Yes, but then you have to go to full screen and first slide. Yes. Correct. You can start.
Good afternoon, everyone. Today I am going to present ocular findings in systemic lupus erythematosus, and I have been mentored by Dr. Manushri Gautam. The systemic lupus erythematosus is the chronic multisystem autoimmune disease. As the treatment involving SLE, ocular findings are very important as they may be the initial manifestations of the disease. The findings may be due to disease itself or may be the complications of systemic or the topical treatment. Pathogenesis. The predisposing factor along with the abnormal immune response lead to formation of the autoantibodies immune complexes which causes the inflammation resulting in the damage. The ocular findings in SLE. It will be present as orbital of the external eye disease, ocular surface disease, corneal involvement, scleral episcleral involvement, uveal involvement, retinal choroidal involvement, neuro-ophthalmic findings, and ocular complications of systemic therapy. The orbital and the external eye disease. It may be present as orbital pain, blood vision, anophthalmos, chemosis, restriction of the ocular motility, lupus paniculatis, discoid lupus type of the rash over the eyelid, acute proptosis. So the mainstay of the treatment is systemic hydroxychloroquine. To control the severe inflammation, we use the corticosteroid. Other drugs are the immunomodulators. Ocular surface disease pathophysiology is mononuclear cellular infiltrates of the lacrimal gland decrease the tear secretion, which results in the keratoconjunctivitis sicca, which causes the upregulation of the cytokines, and finally chronic conjunctivitis. The signs and the symptoms are the foreign body sensation, mild irritation, redness, severe pain. The treatment as we treat the dry eye. The corneal involvement, it may present as the corneal epithelial defects, corneal ulceration, corneal vascularization, and the corneal scarring. Peripheral corneal infiltration, interstitial keratitis, endothelitis, keratoconus. The pathogenesis is immune complexes in the basement membrane of the endothelial cells of the limbal blood vessel, which cause the release of the chemotactic cytokines, and this results in the peripheral corneal infiltrates. The treatment is the topical steroids. The sclera, episclera, and the uveal involvement. It may present as anterior diffuse scleritis, anterior nodular scleritis, necrotizing scleritis, episcleritis. The treatment is the episcleritis treated with the non-steroidal or the steroidal eye drops. And the scleritis indicate the activity of the underlying systemic disease which necessitates the systemic therapy. Anti-glaucoma drugs are given if the scleral thinning is present. Non-granulomatous anterior uveitis is the rare. It leads to diminution of vision and hypopia on formation. The adjacent scleral inflammation may also lead to the mild uveitis. Treatment as we treat the case of the uveitis. Retinal and the choroidal involvement. Accumulation of the immune complexes in the small vessels leads to formation of the lupus retinopathy, which may present as a cotton wool spots, retinal vasculitis, retinal hemorrhages, and retinal hard exudates. When the accumulation of the immune complexes in the large vessel, it will lead to formation of CRVO, CRO, or BRVO. These are some of the pictures which are showing retinal artery or the vein occlusion, AV crossing changes, macular pigmentation, vascular toxicity, and arteriolar narrowing. The complications and the sequelae. Complications can be vitreous hemorrhage, retinal traction, and the detachment, and the retinal necrosis can be caused due to infection of the HSV, CMV, and vis-a-vis. Retinal scarring is the sequelae. So lupus choroidopathy is the one of this problem, and we treat the case as we treat the retinopathy case. Neuro-ophthalmic findings. Optic neuritis, ischemic optic neuropathy, papilledema, diplopia, internuclear ophthalmoplegia, nystagmus, ocular motility abnormalities, ptosis. Treatment is the corticosteroid or the pulse cyclophosphamide. The ocular complications of systemic therapy. The chloroquine toxicity. Earliest sign of the retinal toxicity is the stippling of the retinal pigment epithelium at the macula, irregular pigmentary changes, loss of the foveal reflex. When it becomes severe, it may present as bullseye maculopathy. The pathogenesis is melanin-bearing cells in the retinal pigment epithelium acts as a sink for hydroxychloroquine. Accumulation of the hydroxychloroquine causes the toxicity to the photoreceptors and resulting in the toxic maculopathy. The risk factor for the development of the chloroquine toxicity: dose more than the 5 mg per kg per day of the actual body weight, duration more than the 5 years, kidney or the liver disorder, elderly people, pre-existing retinal disease or the maculopathy. So the chloroquine toxicity may be present as the photophobia, scoliosis, cataract, extraocular muscle palsy, optic neuritis, anterior uveitis, cornea verticillata, toxic maculopathy. The tests for the retinal toxicity are the visual acuity, color vision, Amsler grid, slit lamp examination, fundus photography, OCT, perimetry 10-2, multifocal ERG, fundus autofluorescence. The take-home message is, if the SLE is present, systemic immunosuppression is necessary. If the uveal involvement is present, topical steroid cycloplegic drugs are used. Ocular complications of systemic therapy, routinely monitoring is done once a year after the 5 years of the treatment with the hydroxychloroquine. Corneal involvement, topical steroids, retinal and the choroidal involvement, anticoagulants, laser, vitreoretinal surgery, sclera episclera involvement, non-steroidal or the steroidal eye drops along with the anti-glaucoma drugs if necessity, and ocular surface disease, lubricants with the environmental measures, and neuro-ophthalmic findings, steroids, cyclophosphamide is used. Thank you.
Thank you, Dr. Kritika, for a wonderful presentation on SLE, and not only covering the SLE, but its drugs used in SLE. What is the name of maculopathy which is caused by that chloroquine?
Bullseye maculopathy, ma'am.
Perfect. Now, the topic is open for discussion. Anybody can ask the question.
Dr. Kritika, very nice presentation. What are the differential diagnoses for SLE?
Sir, the differential diagnosis for SLE can be the other autoimmune diseases like the Apla syndrome, rheumatoid arthritis, like this.
And Sjogren's?
And Sjogren's syndrome, sir.
Dermatomyositis?
Yes, sir. Dermatomyositis can be there.
How do you diagnose posterior segment findings with SLE? How will you diagnose that the patient has posterior segment findings with SLE?
So the posterior segment findings, first of all, we will do the visual acuity testing. Along with that, the color vision test is done, and Amsler grid test is also done. And the further diagnosis can be done with the OCT and perimetry 10-2. If the availability is available there, then ERG is done. And for fundus examination is necessary.
Yes. So basically, fundus examination is what is mandatory. That's how you will diagnose that the patient has SLE. OCT has no role in playing diagnosis or diagnosis of SLE. As you said, OCT has no role. Only probably Octa can help you, which is the higher or the high definition OCT or the but what will help you in diagnosis SLE in posterior segment is angiography, wherein you will look for leakages or blockages. And fundus examination. No one would be doing ERGs for diagnosing SLE on fundus features.
Yes, sir. Okay, sir.
Otherwise, nice presentation, Dr. Pratik.
Thank you, sir.
How will you diagnose SLE per se? Because it is very important, because it is not the ocular manifestation we have to treat. It is the SLE to be treated by the medical person also. So how will you label it as a SLE?
Sir, there is a SLIC criteria. According to that, the various involvement has been checked, like the oral manifestations are checked, the rash is checked, renal involvement, then gastrointestinal involvement, neuro-ophthalmic involvement. This is the way different 11
arthritis.
areas are there.
And arthritis also.
Yes, sir. Arthritis, and out of that 11 criteria, if the 4 are present, then we will diagnose it as SLE.
Nice presentation, Kritika.
Thank
You have covered a very vast topic in the given time. Can you tell me what are the risk factors for developing hydroxychloroquine toxicity?
And the risk factor for developing hydroxychloroquine toxicity is the using hydroxychloroquine for more than 5 years, using it for more than 5 mg per kg per day of the actual weight. And if the already toxic maculopathy has been present, elderly patient, if the renal disease is present, and in somewhat hepatic disease present.
Also, if there is any pre-existing retinal disease, that is also a risk factor for developing hydroxychloroquine toxicity. Thank you, Kritika.
Thank you, ma'am.
Thank you, Kritika and judges. Now we move on to our next presenter, Dr. Priya Singh from again MGM Medical College, and the mentor is Dr. Neetu, and she will be presenting on proptosis evaluation.
Ma'am, am I audible?
Yes.
Good evening, everyone. Ma'am, my screen is visible.
Just make it full screen, please. Yes, now you can start.
Just a second, ma'am. Good evening, everyone. Today, I'm presenting on a topic of proptosis evaluation under the guidance of Dr. Neetu Kori, ma'am. What is the objective of clinical evaluation of proptosis? It is determination of probable equality with the plane of imaging. Now, what is proptosis? It's the abnormal forward protrusion of eyeball beyond the orbital margins. Pseudoproptosis need to be ruled out as false impression, for example, unilateral lid retraction, ptosis of the contralateral eye, and high myopia. This is the algorithm for approach to a case of proptosis, which includes history, ocular and systemic examination, and investigations. What are the 6 P's of proptosis evaluation? That is pain, progression and proptosis, palpation, pulsation, and periocular changes. We begin with the history of pain. Is the pain at rest or with the eye movements? Is it constant or intermittent? What is the distribution of pain and what is the severity? Is it dull, boring? It is moderate or severe, as in case of orbital cellulitis or abscesses. Now we comes with the history of progression, whether it is acute, subacute, or chronic. Chronic, as in case of orbital varices, cavernous hemangioma, and etc. Past and medical history of the patient should be taken for thyroid toxicosis, chemotherapy, smoking, previous surgery, or any trauma, and the family history should be excluded for neurofibromatosis. In ocular examination, vision can be decreased due to astigmatism, exposure keratopathy, or optic nerve compressions. Eyelid signs that we can get is lid retraction, lid lag ophthalmos, or S-shaped lid deformity. Conjunctiva may show chemosis in severe inflammation and salmon-colored patch in lymphoma. Dilated episcleral vessels can be found in CCF. Cornea may be looked for exposure keratopathy and dry eyes. Iris may show Lisch nodules and pupil may show relative afferent pupillary defect. Differential IOP should be noted for Barley's signs. Now, the ocular motility limitations can be present in myositis, mechanical limitation by any mass, compression of nerves, or cavernous sinus thrombosis. Fundus should be examined for disc edema, disc pallor, and optociliary shunt vessels. Systemic examination should be done thoroughly for thyroid, ENT examination, and primary tumors elsewhere in the body. During inspection, look for temporal fossa fullness in the meningioma, the direction of dystopia seen, and periorbital changes like ecchymosis, scars, and eyelid lid shape. Proptosis can be unilateral, as in cases of trauma, lymphoma, orbital cellulitis, and it can be bilateral as in case of Graves' disease and cranial dysostosis. Now through this video, we will see the palpation. Palpate for any mass and whether a finger can be insinuated between the mass and the bony orbital rim. If any mass is present, look for its extent, border, shape, size, etc. Skin over the lesion is examined for temperature as shown, and then tenderness is checked, followed by a retropulsion test which may indicate a tumor. The pulsation best detected on lateral view while using applanation tonometer. For example, carotid cavernous fistula, AV malformations and aneurysms, or due to any defect in the orbital wall, we can see and feel the transmittal pulsation. The auscultation of orbital bruit can be heard via bell part of the stethoscope in carotid cavernous fistula. Now completing the examination by worm's eye view, that is below in front of the patient, and Nefziger's view, that is standing behind the patient. The measurements includes asymmetry of 2 mm or more between the eyes, or protrusion greater than 21 mm is significant. Measuring proboscis method, as it can be used for non-visual proboscis also. Second is loose acceptalometer, which is mainly used for children. The third most commonly used one is Hertel's acceptalometer, and the fourth one is Nagel's acceptalometer. Investigations may include complete blood count, thyroid function test, Cassoni's test, Montauk's test, and imaging studies might include CT scan, USG, and MRI to locate the size, position, and shape of the mass. Measuring proptosis on CT scan. Yes, it is possible by Hillel and Proper method. In this radiographic image, we can see an interzygomatic line and a perpendicular from each corneal apex to this line is drawn. And if each line is more than 21 mm or if asymmetry between two is more than 2 mm, it indicates abnormality, that is proptosis. Now my take-home message would be, if a patient comes with a prominent eyeball, rule out pseudoproptosis first. And true proptosis can be evaluated for the presence of mass or not. If no mass is present, check for the inflammation. If inflammation is present and a middle-aged lady comes with a lid lag, lid retraction, heat tolerance, then we can suspect for a diagnosis of thyroid eye disease. And if it is related to fast progressing proptosis, fever, and pain is present, we can diagnose orbital cellulitis also. If inflammation is present with vasculitis, we can go for Wegener's. And if there is no inflammation, we can go for trauma and structural disease. And if any mass is present, mass can be vascular as in CCF, it can be cystic as in dermoid cyst, or it can be neoplastic also, confirmed by the imaging studies. Now lastly, the proptosis can be axial or it can be non-axial. The axial proptosis can be in Graves' disease, optic nerve glioma, or meningioma. And non-axial can be, it depends on the direction of proptosis. For example, if the eye is down and out, the pathology can be seated at the nasal side, that is rhabdomyosarcoma or frontal sinus mucosa. If the eye is downwards and inwards, the pathology can be seated at the temporal side, that is the tumors of lacrimal gland, dermoid, etc. Likewise, the proptosis can be upwards and outwards also in any direction. Thank you.
Thank you, Priya, for wonderful presentation on proptosis. As you suggested, the proptosis can be varied causes like trauma, inflammation, infection. Then it has a various locations, can be axial or non-axial. But then we can have a differentiation according to the age, because when in a clinical practice, you can see first what is the age, like below 12 years, these are the common etiopathogenesis which are related to proptosis, then middle-aged and then old age. So when you divide it into age-related proptosis, probably that clinching the diagnosis are allowing the investigations will help you. So you could have added one more slide according to the age. Otherwise, very nice presentation. Rakesh, you want to say something?
This is very nice presentation. So my question is that is there any relation between the smoking and thyroid eye disease?
Yes, sir. It has been noted that smoking is related to thyroid eye disease. It is related to thyroid hyperthyroidism. So it can be indirectly related to thyroid eye disease also, that is Graves' ophthalmopathy.
So the history is very important to actually smoking history, but in this type of disease, the proptosis, because you did not mention this there. Okay, thank you.
Anyone else?
What is the cause of recurrent proptosis, Priya?
Ma'am, recurrent proptosis, if the proptosis, if you're finding an etiology and if you're not able to treat that etiology, for example, it is if it is Graves' ophthalmopathy, and if we are not able to bring the patient in the euthyroid state, and if the patient is not compliant with the treatment, the proptosis can revert back and it can come again related to if the patient is failing upon hyperthyroidism. Or recurrent can occur in cavernous hemangioma also, and orbital varices. which can be a transient and intermittent proptosis?
Actually, recurrent proptosis, that is a term given in the textbooks, which is classically associated with lymphangiomas. Lymphangiomas are benign vascular malformations seen in children and young adults. And whenever the child gets an upper respiratory infection, the proptosis increases, and the cause is the presence of lymphoid tissue within the stroma of the tumor. While the orbital varices that you were mentioning, they are associated with intermittent proptosis. Whenever the patient bends down or performs the Vassalva maneuver, the proptosis appears.
Yes, ma'am.
Thank you, Priya. Nice presentation otherwise.
What happens in traumatic proptosis, because it is an emergency to manage in time?
Sir, traumatic proptosis can lead to carotid cavernous fistula also, which can cause pulsatile proptosis. And the patient can present with chemosis and lid swelling. And the patient should be taken for immediate surgery.
And what is subluxation of globe because of trauma?
Subluxar globe is displaced out of the orbital rim margin in any direction. That is.
So the treatment is?
So if we are going to orbital decompression surgery,
immediately do a torsography to decompress. That is very important to save the vision.
Yes, sir.
What is exorbitism?
Ma'am,
exorbitism?
Yes, ma'am. The orbit is shallow, but the contents of the orbits are normal.
Right. An example of exorbitism?
Ma'am, congenitally, craniosynostosis can be...
Craniodysphacial synostosis, right. Thank you.
Yes, ma'am.
Perfect, Priya. Very well presented and answered. Now we move on to our next presenter, Dr. Haritima Sharma. She's from SAMS and mentor is Dr. Shreya Thatte, and she will be presenting on amniotic membrane grafting.
Hello, good evening, ma'am.
Good evening.
I'm sharing my screen.
We can't see you, Haritima.
Trying.
Can you see?
Priya, have you disconnected your sharing? Priya?
Yes, ma'am. Yes, ma'am.
Okay.
Haritima, do you need any help? Are you able to see share screen? Yes. Perfect. Go to slideshow, please.
Yes, ma'am.
You can start.
Good evening, everyone. Today I'll be presenting amniotic membrane graft. The amniotic membrane is the innermost layer of the placenta with a size of about 0.02 to 0.05 mm. It consists of 5 layers with 3 basic layers: epithelium, thick basement membrane, and avascular hypocellular stromal matrix. D. Roth in 1940 used amniotic membrane to reconstruct the socket having symblepharon. In 1946, Sorcy and Simmons used amniotic membrane in chemical injury caused by alkali injury. In 1993, Battle and Perdomo used amniotic membrane in recurrent pterygium, dermoids, Gudderson procedures, fornix reconstruction, and alkali burns. And John et al. Used in toxic epidermal necrolysis. Why is AMT useful? It is easy and unlimited, having unlimited availability. There is no immunological rejection, having antifibroblastic activity, preservation for it can be preserved for the future use. It has antimicrobial properties. It has a promoter of cell growth and migration. The function and properties of amniotic membrane: reepithelialization. Amniotic membrane reinforces adhesion of basal epithelial cells. It promotes epithelial differentiation and prevents apoptosis of epithelial cells. It reduces scarring. It suppresses TGF beta signaling that prevents myofibroblasts differentiation. It has anti-inflammatory properties, having a rapid apoptosis of polymorphonuclear neutrophils. It suppresses interleukin-1 alpha and interleukin-1 beta upregulation. It prevents angiogenesis. It has immune privileged tissue having amnion expresses HLA G that suppresses infiltration of CD4 plus and CD4 T cells into amnion. It has high tensile strength that contributes by the compact layer. It has antimicrobial and antiviral properties. The nerve regeneration is there. High levels of nerve growth factor is there, so it promotes subepithelial nerve regeneration. It can be used in corneal surface reconstruction, where chemical injuries, acute and chronic stages of Steven-Johnson syndrome, bullous keratopathy, non-healing stromal corneal ulcers, perforations and thinning after superficial keratectomy and PEDs. It can be also used in conjunctival surface reconstruction, having chemical and thermal injuries, surface healing in acute Steven-Johnson syndrome, pterygium surgeries, cicatrizing conjunctivitis, leaking blebs, filtering surgery, and conjunctivochalasis. It can be used in ocular surface reconstruction, OSSN after OSSN excision, fornix and eyelid margin reconstruction, and similar release. Principle of surgery: amniotic membrane is very popular either as a onlay transplantation or inlay transplantation or a combination of both. In onlay transplantation or patch technique, it is done by patching the cornea as stromal side up with basement membrane downwards. It is sutured to the surrounding perilimbal conjunctiva and acts as an biological BCL to protect the healing conjunctiva beneath it. In retransplantation or graft technique, amniotic membrane tailored to the size of the defect act as a scaffold for epithelial cells merges with the host tissue, and it is secured with basement membrane side up to allow for migration of surrounding epithelial cells on the membrane. Layered technique: it is done by filling entire depth of the ulcer crater with small pieces of amniotic membrane, a larger graft sutured to the edges of the defect in inlay fashion. Additional patch may help in preserving deeper layers for longer duration. Outcomes: in cicatricial conjunctivitis, having greater patient comfort, it reduces surface inflammation and absence of recurrent corneal erosion. In chemical and thermal injuries, it causes pain relief and rapid epithelialization in modern grade burns. In conjunctival tumors and OSSN, superior postoperative cosmesis is there. Ability to clinically monitor local recurrence of tumor beneath amniotic membrane graft. In PEDs, it facilitates epithelialization, and amniotic membrane provides adequate hydration. It protects from abrasive effect of abnormal palpable conjunctiva. These are few cases having acid burns 2 days after the injury and first post-op day following AMT, and 2 months following AMT, we can see there is a clear cornea. We also have OSSN involving superior limbus of the left eye and having fleshy nasal pterygium preoperatively and postoperatively. Complications and limitations: infections, dislocation, and early disintegration of membrane can be there. In corneal perforation more than 3 millimeters, amniotic membrane is incapable of providing tectonic support. In extensive stem cell loss, amniotic membrane is ineffective in replacing stem cells. In severe dry eye, amniotic membrane transplant resulted in failure. Mechanical factors like trichiasis, entropion, dystrichiasis need to be corrected prior to amniotic membrane transplant. In newer preserved forms such as low heat dehydration, dehydrated amniotic membrane, and are now commercially available. Sutureless application with fibrin glue makes the procedure more comfortable for the patients. And AMX is a topical application of amniotic membrane extracts. Singh et al. Have devised Procera, which comprises amniotic membrane attached to soft contact lenses conformers for easy insertion. These are few pre and post-operative amniotic membrane transplant. Thank you.
Thank you, Haritima, for wonderful presentation. How do you make amniotic membrane sterile, and how do you preserve it?
Sterile.
You have to prepare amniotic membrane before putting into the eye,
Yes,
where
ma'am.
it is stored and how it is being prepared from the placenta. Is there any method you know?
No, ma'am.
So there is a protocol how to use it, where to store it. So probably you could have added into your presentation. Thank you so much. Judges?
Is there any role of amniotic membrane in glaucoma surgery? Haritima?
Yes, sir.
Is the amniotic membrane is used somewhere in glaucoma surgery?
No idea, sir.
She doesn't know, you can just explain. Pankaj?
Blood.
Yes, it is used for leaking blebs.
Dr. Haritima, nice presentation. On the same lines, is there any role of usage of amniotic membrane in posterior segment surgery or any retinal surgeries? Can it be used? Dr. Haritima, could you hear the
If
question?
you doesn't know, just say I'm not aware of it.
Just for recalcitrant or chronic macular holes, or when the initial surgery has failed. So amniotic membrane can be used for non-closure holes or recalcitrant holes.
So the amniotic membrane can be used from lid to the retina in various ocular conditions, because it's basically a supplement to reconstruction. Anyone else?
Next.
Which amniotic membrane is better, Haritima? The cryopreserved one or the lyophilized one? Which is most commonly used?
Ma'am, lyophilic. Lyophilic is more commonly used.
Cryopreserved one is better, as you keep on drying or dehydrating it, the growth factors keep on decreasing. The lyophilized one is commercially available, while you get the cryopreserved ones from the eye banks. And actually, the cryopreserved ones are considered better than the lyophilized ones.
Yes, ma'am.
Nice presentation otherwise, Haritima. Thank you.
Thank you, ma'am.
So with this, we come to the concluding presentation of the webinar series is by Dr. Ishita Batra. She is also from SAMS, and mentor is Dr. Shreya Thatte, and she will be presenting on ROP guidelines and classification. It's a big topic. You have to keep a watch on 5 minutes. Dr. Ishita?
Good evening, ma'am.
Good evening.
Let me start.
Meanwhile, I request all the judges to send their judging sheet to Dr. Pankaj, so that Dr. Pankaj can compile and we can announce the results early as possible, because these two winners have to present and prepare for 9th April. Dr. Ishita, you are visible. Make it slide screen and go.
Are my slides visible?
Yes, you can start.
Good evening, everyone. I'll be presenting on the topic retinopathy of prematurity. It was first described by Dr. Terry in the year 1942. It is a multifactorial vasoproliferative retinal disorder. It is the leading cause of childhood blindness in premature infants. Incidence of ROP in India is 38 to 47%, which is attributed to the fact that there is now increased survival of the preterms. The pathophysiologically is basically the arrest of normal retinal, neuronal, and vascular development, which occurs in two phases. Phase 1 is characterized by the cessation of normal vascular growth, and phase 2 is characterized by pathological vessel growth. In phase 1 ROP, there is prematurity leading to relative hyperoxia, which suppresses the oxygen-regulated angiogenic growth factors. Along with, there is also lack of other crucial factors like omega-3, 6, insulin-like growth factor 1, which ultimately leads to the cessation of normal vascular growth. In phase 2, there is hypoxic retina, which leads to increase in growth factors. New vessels develop, and they poorly vascularize the retina. They are leaky, leading to fibrous scar formation and ultimately retinal detachment. The pathophysiology, in uterus, there is normal vessel growth. When there is premature birth, there is decrease in growth factors, which leads to phase 1, the vessel growth stops. Now there is increased metabolism leading to hypoxia, leading to increased vascular endothelial growth factors and other growth factors, which leads to retinal neovascularization. In early treatment and the prevention of phase 1, we supplement growth factors. There is control oxygen exposure. There is supplementation of omega-3, which leads to resolution. And in phase 2, there is anti-VEGF treatment, and we need to inhibit the VEGF for resolution. There are multiple risk factors: prematurity, low birth weight, prolonged oxygen exposure, apnea, hyperglycemia and insulin use, poor postnatal weight gain, sepsis, systemic fungal infection, and history of blood transfusion. The classification is very important. So the zone 1 is characterized up to the 2 disc diameter area of the disc. The zone 2 is which includes the macula. The zone 2 is characterized by 1 disc diameter area, then and which leads measuring up to the nasal part of the oral, touching the nasally ora serrata nasal. Then zone 3 is characterized by the remaining crescent. There is another classification in stages. Stage 0 is represented by the stopping of vessel growth. In stage 1, there is demarcation line. In stage 2, there is ridge development. In stage 3, there is fibrovascular proliferation. In stage 4 and stage 5 are characterized by retinal detachment. Stage 5 is basically total retinal detachment. The plus disease is characterized by abnormal dilatation and abnormal growth of vessels. The regression of ROP. There is decreased dilatation and tortuosity of retinal vessels, which is caused by therapy. In laser therapy, they approximately 7 to 14 days. In anti-VEGF therapy, approximately 1 to 3 days, we can get the results. The reactivation of ROP is characterized by vascular changes, which includes recurrent vascular dilatation and tortuosity. There can be hemorrhages, which are more prominent around fronds or extraretinal vessel developments. Extraretinal fine new vessels of fibrovascular ridges also develop. The screening guideline 2020 indicates the ROP should be screened with babies less than gestational age 34 weeks, or birth weight less than 2000 grams, irrespective of gestational age. The gestational age between 34 to 36, or with any risk factors which I have described earlier, they should be screened for ROP. The risk factors also include the need for respiratory support, oxygen therapy for more than 6 hours, sepsis, if there are episodes of apnea, or there is any need for blood transfusion. The National Neonatology Forum 2020 states the timing of ROP screening. in 29 to 34 weeks of gestational age, the first screen should be between 3 to 4 weeks after birth. Less than 28 weeks or less than birth weight 1.2 kgs, the first screen should be between 2 to 3 weeks after birth. The screening must be done before 30 days of life. The screening should be done under a radiant warmer in NICU. The baby should be wrapped in a mummy wrap, and the feeding should be stopped 1 hour prior to examination. Both pupils should be dilated with diluted triacil plus. The examination should be performed under topical anesthesia without any sedation using indirect ophthalmoscope and a 20 diopter lens. For deciding about the need of treatment of ROP, it is divided into type 1 and type 2 based on ETROP. Early treatment retinopathy of prematurity. Type 1, which needs treatment, any disease of zone 1, any stage ROP with plus disease. In zone 1, stage 3 ROP without plus disease, you need treatment. In zone 2, stage 2 or 3 ROP with plus disease or any form of aggressive ROP in any zone. Type 2 ROP, they need close follow-up. The zone 1, in zone 1, stage 1 or 2 ROP without any plus disease can be followed without any treatment. In zone 2, stage 3 ROP without any plus disease. The management is by laser therapy. Diode red laser used. Laser photocoagulation by indirect ophthalmoscopy is done. Aim is to ablate the entire avascular retina up to ora serecta. The follow-up should be at 2 weeks from their treatment. You can see the picture as well. The cryotherapy. It is not used nowadays. A cryo probe is applied to external surface of the sclera and areas peripheral to the ridge of ROP, which are frozen, and until the entire interior avascular retina has been treated. It was reserved when there was no view for a laser treatment, such as in cases of poor pupillary dilatation or vitreous hemorrhage. Management is done by also done by drugs. Anti-VEGF therapy is used. Intravitreal bevacizumab, ranibizumab, and its biosimilar are being used. The principle is to inhibit VEGF-driven retinal neovascularization. The dose is very important: 0.625 milligram and 0.025 ml of solution for 1 eye. The prognosis. Short-term prognosis, a stage 1 or 2 ROP, there is a spontaneous regression is seen. Type 1 ROP, 31.5% regresses without any treatment. In type 2, 77% regresses without any treatment. Any zone 3 disease, there is excellent prognosis if promptly treated. Prognosis is also affected by amblyopia, astigmatism, cataract, glaucoma, high myopia, strabismus, and anisometropy. Prevention is better than cure. The pyramidal prevention is by to prevent preterm births. The primary prevention is to give antenatal steroids to mother, to use oxygen judicially, which is very important. There are specific and strict guidelines nowadays in NICU to provide oxygen between 90 to 94%. Early nutritional support, adequate physiological postnatal weight gain, prevention of infection, kangaroo mother care, and awareness and education on ROP is very, very important. Secondary prevention is done by early screening and detection of ROP, followed by treatment. The tertiary prevention or rehabilitation is very important, which is done by, there is any intervention in cases of retinal detachment or retinal surgery is performed, treating complications and function of visually challenged children, correction of refractive errors, rehabilitation, and low vision service. The take-home message would be to prevent, mainly there is judicial use of oxygen should be ensured. The people should be, whom to screen is very important, less than 34 weeks of gestational age, and if more than 34 to 36 weeks, if there is any presence of risk factors, or whenever the pediatrician demands. When to screen, less than 30 days postnatally. Educating the parents about need for regular screening is very important, and proper documentation of ROP is very important, since it is so legal cases can be formed. Thank you so much.
Thank you, Dr. Rishita, for presenting the whole ROP in 5 minutes. Thank you. Judges want to ask anything?
Dr. Ishita, very nice presentation. You've been very wonderful with this. Just one question. How do you and where do you see these
Stop
babies?
sharing, beta.
Like, just give me a minute.
Yeah. Dr. Ishita, where do you see these babies?
NICU, and the fall after discharge, they also come to sometimes to OPD as well. After discharge, if they're stable enough.
So when you screen and you just mentioned the zones, zone 1, 2, and 3, which is very, very clinically important, how do you clinically say that this is zone 1? What can you determine this is zone 1 and not zone 2? Because the zone 1 and zone 2 will make a lot of difference in the treatment modality for ROP. What is zone 1? How do you clinically say, Dr. Ishita?
Clinically, the two disc diameter around disc involving the macula, and in zone 2 it reaches nasally up to ora serrata. So it is although it is comes with experience and majorly, but
we are going wrong. Dr. Ishita, zone 1, when you click, what you said was diagrammatically, which is 2 disc diameters, but clinically you use a 28 diopter lens to diagnose and sense. Yes. And if the nasal margin of the 28 diopter disc is touching the disc, nasal disc, then the temporal aspect is zone 1.
Yes.
So this will help you determine that this is zone 1 and not zone 2 by just putting the lens. And if the lens nasal margin touches the temporal aspect of the field that you're seeing, that is zone 1 of ROP. Yes. What is the preferred dilating eye drops that you use for ROP dilatation?
Triazole plus in the method 1:4 dilution used.
No, tropical phenylephrine should be avoided. Plus will constitute of propicacil and phenylephrine. Phenylephrine should be avoided. The preferred drops is only plain tropicamide, or there are other ways to reconstitute these drops. What is the role of using anti-VEGF?
To suppress the to suppress new vascularization.
That can be done with laser also. When would you indicate the use of anti-VEGF in ROP? Well, one of the major indications is AP-ROP, which is acute posterior ROP, and the other is half zone disease of ROP, where you need anti-VEGF and laser is very ineffective. Yes. What is the endpoint that we look forward to when we laser these patients, these babies? How do you say that the ROP is resolving or there is regression of retinopathy or prematurity, Dr. Ishita?
Regression is being said when there is decreased dilatation and decreased tortuosity of the retinal vessels, and there is no progression.
Fine, that's all I have.
To what age you will do the long-term follow-up of this ROP patients? At what age you will do this follow-ups? Up to what age?
I don't know the exact criteria, sir.
Up to 5 years you have to watch. Even it is lasered or not, up to 5 years you have to do the follow-up.
Yes.
Does the follow-up change if you're using laser and if you're using anti-VEGF?
As I said, I have no.
If you're doing laser, you have to follow them up till 40 weeks, and if you're doing, if you're using anti-VEGF, then the follow-up slightly extends to 52 weeks. And thereafter, again, it is like 3 monthly, then 6 monthly, and as Dr. Pankaj rightly said, till 5 years of age.
I think with this we can close this webinar series, and I would like to thank President FPSOs Dr. Ashok Singhai, Secretary Dr. Rajiv Gupta, all the mentors, teachers, coordinators, judges, They were all there for all the 6 webinars, sitting continuously for 2 hours and just helping these budding ophthalmologists. A special mention to the coordinators, Dr. Shweta, Dr. Pankaj, and Dr. Aditi. They did a wonderful job. It's a collaborative effect, and it's our first efforts. Probably with time, we are going to improvise such kind of a series. And the final will be in Jabalpur. I would like all of you to be there and witness this final. And hopefully we will keep good prizes for winners too. Thank you so much. And I would like to thank NVEX division Ajanta Pharma for providing us the platform. Without their support and without their help, we could have not met sitting at home. So I would like to thank Sanjay Jain and Sapna for doing this wonderful thing. Thank you so much, all of you. And PGs, wonderful presentations by all the PGs from all the divisions.
Really nice presentations. And actually, I just want to make one comment. This is the webinar where all the participants finished within the designated time period. This is the only webinar. In fact, I think the topic of the last postgraduate was ROP guidelines and classification, but she finished the entire ROP in the designated time period. So that is, quite an accomplishment.
But that's a learning for all the consultants, and I hope in midterm and in the consecutive conferences where we are presenting, we should keep time limit. And Shubhra, very sorry to say, I'm going to keep limit in all the conferences consecutively to be held, and there will be a podium closer, there will be no mic allowed, there will be no presentation allowed beyond the speculated time, because we don't have a time for discussion. If you keep very lengthy sessions and you just rush, and then ultimately at the end, the moderator and panelists have to say, because of the shortage of the time, we will not discuss anything.
This has been quite a learning platform for everyone, madam, to finish within the designated time period. It's very nice that you kept the time period of 5 minutes.
Yes.
It is due to the marking.
No, but that's a good thing. Like whether you are being judged or marked, but then if we have allotted some time or we have been allotted some time, probably we should restrict to that time unless there is some special situation. And any day, one particular topic can be presented in 5 minutes, one particular topic can be presented in 1 hour. Especially medical teachers know them well, that for whole 1 hour, even sometimes if somebody tells me, I just see 1 hour teaching, it's so difficult. Give me 5 minutes, I will finish it up. So teaching is an art, and everybody should learn eventually down the line that how to give effectively to the participants so that they have some take home. Otherwise, everything is available on Google.
That's true.
Yes. Thank you. Thank you so much.
Thank you,
everyone.
Thank you, Vinita.
Thank you.
Thank you.
Thank you, ma'am. Thank you.